Hi, I'm Allison Yoon, and I'm the pharmacy intern covering the general medicines floor. I see that there is a question regarding our 28-year-old male patient who was admitted for fulminant severe ulcerative colitis that has been made NPO, and it looks like he already received 5 days of IV steroids, the methylprednisolone, 80 milligrams every 8 hours. So we do see that the patient is steroid refractory. I understand that the patient wanted to know the benefits and risks of using high-dose infliximab, the 10 mg per kg dosing, as initial induction therapy rather than starting at the standard 5 mg per kg, which is the FDA-approved dosing. So as we know, the infliximab is a recombinant chimeric monoclonal antibody that binds and inactivates the TNF-alpha. This agent is indicated for use in moderate to severe ulcerative colitis for patients that are not controlled on conventional therapy. So I looked into studies and I found the active ulcerative colitis trials, the ACT-1 and ACT-2. So these two trials are both randomized, double-blind, placebo-controlled trials, and each trial has around 350 patients. So these these trials compared the use of induction therapy, the standard dosing of 5 mg per kg versus the higher dosing of 10 mg per kg of infliximab in moderate to severe patients. And these patients were both corticosteroid refractory and patients that are not corticosteroid refractory. So the way that they measured the clinical response is by measuring the decrease from baseline of the Mayo score. So the Mayo score is actually the stool frequency, rectal bleeding, and findings of UC on the endoscopy. So in the first trial, the ACT-1, when we look at the measurement of efficacy, we see that the both dosings have very similar efficacy. So the 5 mg per kg standard dosing actually had a slightly higher efficacy of 69% in clinical response at week 8 versus 61% of the 10 mg per kg dose. And in ACT-2, we actually see that the 10 mg per kg had a slightly higher efficacy this time of 69% versus 64% of the standard 5 mg per kg dosing at week 8. We also see in the second trial, ACT-2, that the 10 mg per kg actually had slightly lower rate of patients who needed early colectomies, which is a benefit of using the 10 mg per kg, and it did show a slightly higher remission rate and mucosal healing in using the higher dose of 10 mg per kg. But we actually see here that it is a very slight benefit, and it actually isn't clinically or statistically significant. And we see overall that the efficacy is very similar between the standard dosing and the higher dosing. But when we look at the side effect profile, it actually looks like the higher dosing of 10 mg per kg does have more side effects, such as the increased infections. There was actually a patient that experienced a reactivation of latent TB on the higher dosing of 10 mg per kg. And there were higher rates of infusion reactions in the patients that got the higher 10 mg per kg dosing. So overall, we do see very similar efficacy between the standard dosing and the higher dosing, but when we look at the side effect profile, it looks like the 5 mg per kg dosing is safer. So if it is indeed the same efficacy, then I think it is better to go with the 5 mg per kg dosing, which is actually what these two trials also concluded, that the 5 mg per kg should be the standard dosing. So overall, I recommend starting induction therapy for this patient. So a dosing of 5 mg per kg IV over at least 2 hours at weeks 0, 2, and 6, and then we could follow up with maintenance therapy. And at that time, then we could decide whether we want to increase the dosing or not. We can also consider pre-medicating this patient with antihistamines, acetaminophen, or corticosteroids. We do want to monitor for the side effects, so possible increased rate of infections such as upper respiratory infections, sinusitis, reactivation of latent TB is a big one, so we do want to assess the patient's risk for that. Infusion reactions, serum sickness, and lupus-like syndromes, and possibly sepsis. We do want to monitor the patient's trough levels. We want ideally a trough level over 2 or 3, because that does indicate that the patient is in clinical remission, which is our goal ultimately. And we do want to eliminate corticosteroid use in the future. So if you have any questions, you can page me at 1234, or you could find me and call at extension 4567. Thank you so much.